So those are 4 real cases spread out over the last 5 or 6 years that we've dealt with the team that I work with at Sick Kids. So what a lot of similarities, I think, in the work we do compared to work Marisa does in geriatric end of life and the work that we'll hear that Rowena does, but some significant differences. The first one being that I'm talking about children, and how many of you in this room came in understanding that children do die in 2009? So it's an unenlightened audience. Because I meet a lot of people who don't know that children die. And that, we live in a society where a lot of children don't die. In Canada, on average, there are 5,000 deaths under the age of 18 years per year, compared to 200,000 adult deaths. So the numbers of children dying are much smaller, and that's a good thing. But we live in a society, not only do we fear death and not want to talk about it, as Marisa already dealt with, but we certainly think that children, how many of you have heard the term, children are not supposed to die? Right? Everybody's nodding. So I went to medical school, and I don't believe that I just fell asleep during the lecture where this was talked about, but I certainly can't find in medical text a line that says children are not supposed to die. I don't know my Bible by heart, but I've not yet come across a passage in the Bible that says children are not supposed to die. People I've worked with from other faiths tell me that it's also not in the Torah, it's not in the Quran, it's not in the teachings of Buddha. It's a North Americanism, right? We'd like it if children did not have to die, but that doesn't mean that we can necessarily stop it all the time. So there's a big societal barrier to the idea of children dying. There's also a great institutional barrier. I work at the Hospital for Sick Children, where for many years our motto was the place where miracle happens, the place where miracles happen. Our new strategic plan is just being unveiled at the hospital, and our new goal is to improve health outcomes for children around the world. So the question I asked when I first heard that was whether death was a health outcome. Because if it's not, I don't see a place for myself in the strategic plan of the hospital. So there's a great institutional barrier. There are professional barriers, as Marisa already alluded to. I went to medical school not to learn how to help people die, but to learn how to make people better. And that's why everyone I know who's a nurse went to nursing school. And that's why social workers choose to work in hospital settings. And that's why occupational therapists and rehab therapists and dietitians became who they are, because they wanted to help make people better. None of us did this because we wanted from the start to help people die a good death. So there's that belief is one of the big differences from adults. The small numbers that I already alluded to, and the fact that children die in my 4 vignettes from a variety of diseases. And that the trajectories of those diseases are quite different. So in pediatrics, for sure, palliative care is much more than end-of-life care. There are children on our service that we've been following for 5 years, 6 years, 7 years, because we're helping these children live their dying. We're helping them live their life to their fullest potential until their end-of-life time comes. Families, children don't come without families. You sometimes wish that they could, but they don't. Children do not come without families. And so, while family played a very big role in all the vignettes that Marisa shared with us, families play a crucial role in the care of children. And parents are in a unique and incredibly difficult position when they learn that their child has a life-limiting illness. Because that's not in any of the parent books. You go to Indigo or Chapters or Coles, and you've got bookshelves that would stretch across this back wall that have books about parenting and teaches you how to parent an anxious child and how to parent an ethical child and how to get your children to eat more vegetables and how to get your children to sleep and how to toilet train your children. There's nothing about how to care for a dying child. There's in the book What to Expect When You're Expecting, What to Expect the First 5 Years, all wonderful books. There's nothing in there about about children who might not live past 5 years. There's not a single paragraph in any of those books that talks about a dying child. And a parent's first role is to protect their child. And so they learn that their child has a life-limiting illness. What's the first thing they feel? They feel failure as a parent, because I couldn't protect my child from this horrible thing that's happening. The other thing that's different is in adults, their family members can act as a substitute decision maker. So in my instance, if I became unable to make decisions about my medical care, the team caring for me would turn to my husband, Evan, and they would not say, Evan, what do you want us to do? They would say, what would Chris want? Hoping that because we've lived together for so long and know each other so well, that he would have an understanding of what it is I would want. Doing the work that I do, I can assure you that my husband has a very detailed list of the things that I would want, would not want, and the ways in which I will haunt him if he does not accede to my wishes, should the need arise. But he's substituting for me. He's standing in for me. He's delivering my message. If he and I were now put in the position where we were making these decisions for our daughter, who's 14, so if she were capable of making decisions, could and should be involved in those decisions. But if she's not able to be part of it, we're making those decisions on her behalf. We're not doing that based on what we know she would want, because at the age of 14, we haven't had these discussions. And try as we might to think about the sort of person Emma is, and what we know about her and what she might want, it would be absolutely impossible for me to separate Emma as a person and think of her without thinking of what I want for her as her mother. It would be absolutely impossible for me to do that. So I would not be substituting for her. I would be surrogating. I'd be a surrogate decision maker. And so I think we always have to keep that in mind with parents, that they have this incredible dilemma, that they cannot think of what's best just for their child without thinking about what they've always wanted for their child, what their hopes and dreams were for their child. The other thing that is different in pediatric palliative care is because some of the illnesses that qualify children for palliative care are inherited illnesses, we meet some families more than once. So think about that. Think about the fact there's one family that we have seen, our team, not me personally. Our team has helped these parents through the death of all 3 of their children. And there are a number of families that we've met twice. And that's a particular type of burden, I think, for these parents. To know while one child's dying that you're going to be going through it a second time is something that I can't quite imagine.